The tummy tucks remove skin. Liposuction is much superior as a procedure for body contouring. Hello and welcome to this edition of the Wise Medical Minute. Today I decided to provide some information, not just for general consumption of the public or not even specifically for our patients, but I wanted to talk about liposuction, one of my favorite topics, but with the target audience being physicians and surgeons who right now do not perform this procedure. Now, there's multiple motivations for doing this. I guess the biggest motivation comes from my experience over 11 years ago when I wanted to learn to perform this procedure and reflecting upon the hoops I had to jump through and all the hassles and the administrative kinds of hassles that were just unnecessary. I'm sure I spent hundreds of hours at very expensive costs attending CME kinds of courses where in reality you only get a glimpse of what you need to know to be able to perform liposuction. So I want to reduce the hassles for other physicians and surgeons learning to do liposuction as one of my primary motives, so you don't have to go through what I went through to become proficient at this art. My second motivation is the basic concepts sometimes come up when, especially plastic surgeons, will ask a patient to go to their primary care doctor in order to get medically cleared to have a cosmetic procedure. Now, in my practice, I don't send anybody to get medical clearance somewhere else. I do my own medical clearance because as a board-certified internist, I don't think someone who's not familiar with this procedure is going to do a better job than me in terms of looking for the things that can go wrong. The issues and complications that arise when you're doing any surgical procedure really have more to do with the pre-existing medical problems or anesthesia and not the procedure itself. So that's of more than routine importance as this procedure becomes more popular. The third motivation for this talk is as we get more and more familiar with liposuction, there's lots of medical benefits from having liposuction that people in traditional plastic surgery type communities just aren't interested in. They don't care that your blood sugar gets better. They don't care that your back pain gets better. They don't care that your blood pressure or your blood sugar are better than they ever were without drugs. These things can be accomplished with liposuction, and we'll talk more about it as we go. But similarly, one of the biggest things that I'll conclude with before we're done today is when you harvest fat, abdominal fat in the adult is one of the most plentiful sources of stem cells. And mesenchymal stem cells are being used for therapeutic purposes, conditions in essentially every organ system. So I think it behooves physicians in all specialties to become more familiar with the procedure itself, even if you don't learn to do the procedure. But as the plastic surgeons have tried to take over this procedure in the last little over a decade or so, it has become less of an office-based procedure and more of a surgery. Now, I don't mean to demean the significance of the surgical techniques, but liposuction traditionally, for decades, was looked down upon by the traditional plastic surgery type folks who like to cut. This is a minimally invasive procedure. We're working with tiny incisions, less than 3 or 4 millimeters in size, and you're removing fat just from under the skin. And there was a time, even when I first started learning about liposuction, that it was kind of a decision women would frequently make. Do I want liposuction or do I want a tummy tuck? Now, the reality is, it's a rare tummy tuck nowadays that isn't combined with liposuction. And the reason is, the tummy tucks remove skin. Liposuction is much superior as a procedure for body contouring. So that's a basic principle that kind of makes me feel like I need to explain this to non-plastic surgeons. Now the irony is, out of the 18 or so physicians and surgeons that I've had the privilege of training, almost a quarter of them are plastic surgeons. And just to reassure the non-plastic surgeons out there, almost all the plastic surgeons who perform liposuction learned liposuction the same way I did. A retired ER doc, board certified in emergency medicine, board certified in internal medicine, more recently in aesthetics. I didn't learn how to do liposuction in my residency. Neither did the plastic surgeons. Okay? So that's a basic concept that I hope gets your attention and makes you want to hear the rest of this talk. What we do with liposuction can safely be performed in an office setting in almost any exam room. Now, as the standard in the industry or the state of the art has evolved, as more and more surgeons get involved with performing this procedure, the standard in some communities has evolved because the people who are performing it now like to work in an OR, they like to work with people under general anesthesia, and they like to cut people. So the nature of the procedure has evolved as the nature of the people performing it have evolved. So the point I want to make is, originally, liposuction as performed today was developed by a dermatologist, at least as far as the Tumescent anesthesia almost universally used to perform this procedure. You can look up Jeffrey Klein. I won't belabor his contribution to the art at this time, but liposuction would not be liposuction without him. Similarly, Jeffrey Klein, before he was a dermatologist, trained in internal medicine. So some of the basic pharmacokinetics of lidocaine that make all this possible were investigated by him and published by him, and I think explained better by him than some of the other folks. And the basic concept, if I can oversimplify, forget everything you learned about liposuction given IV for treating arrhythmias. Forget everything you heard about the toxic levels of lidocaine when given as an intravenous administration. Liposuction is performed in the subcutaneous fat. Lidocaine is notoriously lipophilic. So you don't get the blood levels that cause toxicity if you're putting the lidocaine directly in fat. Now, just to toss some numbers at you, it's rare, if ever, you're going to get in trouble if your total dose of lidocaine is less than 40 milligrams per kilogram of body weight. I traditionally will comfortably go up to 45 or even 50 on occasion. When you get past 55 milligrams of lidocaine per kilogram of body weight, that's when the risks of toxicity become substantial. So that's one basic point that any physician, that's easy math, okay? Now, the other luxury we have when performing tumescent anesthesia is we're taking a layer of fat that might be this thick, it might be that thick, but as we infuse the tumescent fluid, which is basically dilute lidocaine, you're working in a wider space. So the hardest thing to learn when you're doing liposuction is maintaining your efforts within a tissue plane. And the whole concept of tumescent anesthesia is you're making that tissue plane bigger. So you got more room to work. So that's another concept that I can put in a 10-minute video. Now the other thoughts in this regard have to do with use of general anesthesia. I won't say what I was about to say. But the bottom line is this performance under local anesthesia with either oral, IM, or IV sedation is quite safe. You don't need to put people to sleep. And as I always say to patients, there's a whole bunch of stuff not wrong with you if you can talk to me. Okay, so the monitoring required when you put somebody under general anesthesia obviously necessarily is much more intense than the monitoring required when you're using oral or IV sedation. Now, I have an RN doing nothing but vital signs and administering drugs in all my procedures, so we have intense monitoring of vital signs. We monitor O2 sat continuously, waveform EKG continuously, blood pressure every few minutes, urine output continuously. So we do more in the way of intra-procedure monitoring than probably is necessary. I did my first 200 cases with a whole lot less of that stuff. But after being summoned to function as an expert witness for other people being sued, and I looked at the things that the lawyers dwelled upon in the course of suing other doctors. Now, they make a big case out of, you didn't even have an IV in the procedure, or you didn't even have a Foley catheter in the procedure. So that has become the state of the art. I'm not convinced those things are absolutely necessary, but we do it. And I say that to say, starting an IV is no big deal for anybody in almost any specialty. Monitoring urine output is no big deal for almost anybody in every specialty. But similarly, those hemodynamic parameters that are more important can be done by any medical assistant, certainly by an RN. So this does not require an operating room to perform this procedure. What it does require is people skills. You have to be able to explain to people what you're going to do. Then you got to explain that you're about to do it. Then you got to explain while you're doing it. And then after you've done it, you got to tell them what you did. So that is something that not any plastic surgery program I've ever seen. They don't teach people skills in a plastic surgery residency. They should, and maybe they're starting to. In fact, they don't do that in very many other residencies for that matter. But people who have primary care type backgrounds, people who come from OBGYN, internal medicine, family practice, that's not news to them. They know they have to talk to people. Now, in this day and age when everything's governed by what kind of insurance people have, we've lost the art of being compassionate physicians talking to our patients. But for people old enough to remember those days, this will be the part that helps you to excel and do better than a lot of people who have all kind of technical skill that you may not bring to the table. Now, you do need some surgical training in terms of just basic sterile technique. You do need to respect the incisions that you make and a little extra prep here and there. But part of the art of liposuction has to do with working with an awake patient. There's lots of things that you can't do with straight instruments when you're trying to make curves, unless the positioning of the patient can be altered. So that positioning of the patient multiple times during the course of the procedure is really part of the secret to success. You can't do that when they're unconscious under general anesthesia. So that's one of those things that primary care physicians pick up on a lot quicker than surgical types. The surgeons that I've trained, they don't want to hear the patient's mouth while they're working on them. They don't want to hear them complaining. If something's a little uncomfortable, you stop, you give them a little extra local anesthesia. If you've sedated them enough, they won't even remember it. But meanwhile, if you're performing it in that manner, when you're done with the procedure, they walk out, they go home. You don't have to keep them in the hospital overnight. So all those really basic concepts are really the traditional basis for success of liposuction. Now, I mentioned in passing that even if you're not interested in learning to perform this procedure, I think it's important that you are familiar with it when your patient, if you're a primary care doctor, comes to you and needs pre-op clearance for someone who doesn't want to do pre-op clearance before they have a surgical procedure. So yes, you have to make sure they're not anemic. Yes, you have to make sure their liver and kidney function are normal. So they get rid of all these drugs you're pouring into their body. The risks of fluid overload is not trivial. Sometimes a procedure will incur 4, 5, or even 6 liters administered into the subcutaneous space. You know, they have to have a normal pair of kidneys to pee that out. This is not rocket science. If a person has a risk of congestive heart failure, if they have other conditions for which fluid overload is a problem, you don't want to medically clear that person just because they want to have a procedure. I don't care how soon the wedding's going to be or whatever. Similarly, if they are diabetic and their blood sugar is just ridiculously uncontrolled, their risks of infection are substantially higher. So control the diabetes first. You know, in my practice, we do all those things in-house. I don't farm that out to anybody. But if you're the primary care physician, you're not performing the liposuction, pay attention to those things. The tumescent fluid that we use to numb people up with contains epinephrine. If a person's blood pressure is poorly controlled, the epinephrine makes bad worse. Similarly, if the same person with high blood pressure is well controlled, the small amount of epinephrine in the very dilute concentrations that we use does not cause any problems. So you need to be reassured that yes, you can use epinephrine in a well-controlled hypertensive patient, and yes, you can do this procedure in a person with well-controlled diabetes. You got to be comfortable managing diabetes and high blood pressure in that context. Now, I guess one of the things that will attract a lot of physicians and surgeons to learning to do this procedure is it is rewarding financially. In my office, my cost per case is probably twice what everybody else expends. It cost me $2,500 to open up that OR that we have. I don't call it an OR, but it's set up like one. You know, it's a procedure room. We don't use scary terms like operating room around patients. But the procedure room can be embellished to where your costs go through the roof. You don't have to do that. I did my first 200 cases in an ordinary exam room, and the cases came out just fine. You don't have to have a medical, surgical kind of facility that is comparable to what they do at a hospital just because the hospital built one and you're an employee working as a plastic surgeon of the hospital. Obviously, it's a luxury and nice to have, but I would argue to the end of the earth that it's not necessary. It's been shown in very well conducted studies that certain complications like infection and various other things are more likely to happen in a hospital setting or a surgery center type setting than in a doctor's office. So that data is pretty strong. If you want, I can share it with you. And not to mention, in this day and time, the same people who will complain about a $20 or $30 copay will gladly write a check or whip out a credit card if you're going to suck fat out of them. So getting paid is an advantage that should motivate at least some people in this day and time to get interested in it. Now, the more important things have to do with the things we can treat. I always use the illustrative example of what happens to one's blood sugar. And anybody whose BMI is over 28, I do a hemoglobin A1C. Half the patients we see come in with BMIs in that range or even higher. And at least half the people will have an abnormal A1C in the range of 5.7 to 6.2. The same reason they have belly fat that they want to get rid of is the same reason their A1C is above normal. So what we've observed is even when they have A1Cs that meet diabetic criteria, i.e. greater than 6.5, when we perform a liposuction procedure, repeat the A1C in 12 weeks, inevitably the A1C has improved. And the magnitude of improvement is comparable to prescribing metformin or some of the other first-line diabetic drugs. Now, I mentioned that as just an illustrative example, but I want to also point out that there needs to be more collaboration and less territorial, almost Democratic versus Republican type fighting amongst the specialists. Because if we collaborate more and fight with each other less, You know, part of the motivation for this talk is the derogatory terms that people have used in reference to me when they went to get a second opinion from a plastic surgeon. They want to talk about me not being a plastic surgeon. But when they look at my results next to the results of the same plastic surgeon, they come back to me to fix it. And I take offense at that, but you know, we welcome them with open arms nonetheless. Bottom line is, you can observe improvement in medical conditions like back pain, like hemoglobin A1C problems with diabetes, like blood pressure, with just a simple removal of abdominal fat. And as we get into studying more about the benefits of stem cell therapy, or if you're in any way interested in regenerative medicine, you almost have to get interested in performing a liposuction. Now, the thing I want to say about stem cell therapy and regenerative medicine has to do with the potential therapeutic benefits of stem cells. Every organ system has benefited from some kind of treatment with stem cells. The mesenchymal stem cells that you harvest from adult fat have been shown to be able to be converted into cartilage, into bone, into tendon. Our experience, we have very good results with conversion of fat to normal breast tissue. And we know from the oncology and the orthopedic community that anything that's healing benefits. Like if you're trying to have a bone marrow recover, having a source of stem cells after you've wiped out the bone marrow with chemotherapy. Or if you have a broken bone and you want to stimulate rapid healing, you know, those osteocytes that are converted from stem cells, you know, heal the bone a lot faster. So even with neural cells, there's some early data to say that the stem cells have a regenerative potential there. There's better data with things like hair restoration and the rejuvenation of skin when we do anti-aging procedures. The stem cells that come from fat, the stem cells that are recruited by PRP, that's a whole nother talk another day. All those things have to do with stimulating formation of new connective tissue. And that's beyond the scope of just plastic surgery. Any specialist who has any interest in helping people feel better about themselves, look younger, or help them regrow hair, or help them fix their diabetes, there's a potential benefit in you learning more about liposuction. Now, the other thing I wanted to say about the stem cell concept is a lot of charlatans kind of got involved after it was realized what the potential of stem cell therapy was. But in the course of that, it became the usual commercial practice to use umbilical cord blood as a source of stem cells for things like treating arthritis, all right? And it works. I have more than a little bit of experience with that, and these concepts are not undeveloped. However, stem cells come from other places besides umbilical cords. You can get stem cells from bone marrow. That's the traditional source used in hematology and oncology circles. There are stem cells present in peripheral blood. In fact, that's the basis for what we believe the mechanism of PRP, recruiting those stem cells to wherever you put the PRP. But let's talk numbers. When you draw blood, a typical aliquot of peripheral blood will have about 10,000 stem cells per usual amount of blood drawn, like something less than 30 cc's. The bone marrow aspirate, which is a smaller volume, has a higher concentration, more like 500,000 stem cells, and I'll repeat this in a minute. Contrast adipose tissue, 30 cc's of adipose tissue can have as much as 50 million mesenchymal stem cells. So when you're looking for a source of stem cells, this is the most plentiful source. And the beauty is, we've also learned that these stem cells can be replicated in vitro, and they can also be stored for future use for years. So I don't know why it's not more popular to save harvested fat after a liposuction procedure for future use as a source of stem cells. So let's look at those numbers again. Bone marrow, 500,000 cells per typical aspirate. Peripheral blood, 10,000 cells only for typical aliquot. 30 cc's of fat, 50 million mesenchymal stem cells. So the numbers are exponentially greater, and it's awkward, obviously, going around sucking fat. And you do have to set up for a procedure. It does require a little bit of local anesthesia and a little bit of planning, but this is an abundant source of stem cells. Now, the obvious question is, how many stem cells do you get from where they're usually getting them from, the umbilical cord blood? None of the manufacturers who promulgate the stem cells from umbilical cord blood will give me numbers, and I've asked all of them multiple times. They won't give you numbers because the numbers are probably exponentially low, but more importantly, the numbers are not consistent. You can't have a standardized amount of stem cells from multiple different people's babies' cord blood. So that's why I want to advocate for all those people looking at the different things that are treated with stem cells using harvested fat as a source. Now, last but not least, the technology, 2 more points. The technology used to spare people tummy tucks is another thing that I think non-plastic surgeons will master quicker than the plastic surgeons. The irony is, plastic surgeons are jumping on this technology more than anybody else. Not surprising when you think about it intuitively. Similarly, the radiofrequency-based treatments, and I will resist the temptation to use any brand names, or the high-frequency focused electromagnetic treatments that we can use not only to reduce fat, but to actually build muscle. When you remove the fat with liposuction or weight loss or whatever means, you can actually build muscle, to the tune of tens of thousands of contractions, the equivalent of, tens of thousands of sit-ups, and you can build a six-pack in 45 minutes. So when we remove the fat using whatever technique, whatever technology, we got all these other technologies not only to tighten skin, but to build muscle. So from the aesthetic and cosmetic kind of perspective, that's more reason to spare people the consequences of an abdominoplasty when they have a scar from stem to stern, and they have an incision that takes weeks to heal, and have a deformed belly button for the rest of their lives. And with the technologies available to us, both minimally invasive, like the plasma therapies, or non-invasive, like the radiofrequency-based treatments, with or without microneedling, there's lots of technologies that'll do amazing things for skin tightening, and you can spare people the downtime and the risks of infection and the scars that result from these invasive abdominoplasty type procedures. So non-plastic surgeons will be a lot more interested in procedures where you spare people getting cut. Last but not least, that's about the 3rd time I've said that, I want to make it clear that there is a body of knowledge, a body of skills that you cannot learn from a video, you cannot learn from an online course, you cannot learn in a weekend course. You can be exposed to these things, but most of the courses that I attended were after having learned this skill, number one. So fortunately, I was not dissuaded, but a lot of the courses are taught by people who deliberately want to mystify the art of liposuction so you don't leave the course feeling comfortable that you can perform this procedure. That's an accusation that I'll stand by because I've attended most of the courses. But the bottom line is, with some hands-on proctoring, if I can use that term, there's nothing that's difficult or rocket science kind of magnitude of learning that requires this. You know enough about anatomy, no matter what specialty background you come from, to stay out of the peritoneum, to stay below the skin. You're working in the subcutaneous space. It's not difficult, okay? Similarly, if you're able to understand what's going on, you can explain it to the patient. That's not something you learn in a residency. So I want people to understand that with a little hands-on proctoring by someone who's done this before, I learned more in 4 weekends working with a physician who had been doing these hundreds and thousands of them by that point in time than I did in a whole bunch of courses where we were looking at videos and listening to people who didn't really want me to learn how to be competing with them. So a little bit of hands-on proctoring is something we do offer as part of my practice for physicians. And after some basic knowledge that you can acquire in a matter of hours, building on knowledge you come to the table with, you can be proficient and you can perform this procedure. In fact, I was tempted when I wanted to come up with a name for this talk. I wanted to say, even you can do liposuction, or demystifying liposuction for doctors, but I'll settle for the title, Basic Tenets for Doctors Interested in Liposuction. Thank you for your time and attention, and if you have questions, please email me at info@wisemedicalcenter.com. Thank you.
Thank you for listening to the Wise Medical Minute with Dr. Thomas Locke. Dr. Locke addresses current events as well as important medical issues using responsible, unbiased journalism approached from a medical perspective. We invite you to submit questions or comments or suggestions for future topics by email to info@wisemedicalcenter.com. Again, thank you for viewing the Wise Medical Minute.